The move now with fillers is going more and more natural. You have more natural fillers, but the filler techniques are changing. Doctors are wanting to be more natural. Patients are demanding to be more natural. Have you noticed this in your practice? Have you seen people coming in and becoming a little more discerning, a little more tasteful?
You know, it's funny because it depends on the generation. It also depends on, the practitioner and also their style of business, right? So we have a few businesses around us who are volume clinic, right? So these volume clinics will just get like young people in and they're like, I want lips. And they're like, okay, no problem. Do lips, but it's one technique, same technique for every single person. They come in and they want big lips, and even though they already have overfilled lips, they're gonna go in and they're gonna say like, I want some more lips, and they'll be like, yeah, no problem, because like it's volume clinic. We don't care if you stay. We just want you to keep coming back. So they'll come in and they'll get it done, and it'll look terrible. And then after that, I will end up seeing these clients, and I'm like, oh my gosh, okay, so how am I gonna tell them, well, we have to dissolve first before we do anything else? And they're like, I don't want to dissolve. And the reason why they don't want to dissolve is because it looked good on Instagram, right?
Yeah.
It looks good on 2D, but in real life, people are like, I can see you have duck lips from a mile away, but they don't actually care about that. So it's really interesting because you've got this generation where some of them still feel like, I still just care about how I look on Instagram, but I think most of the population definitely cares about making sure that none of it's detectable. And for me, I say it all the time, like there's a difference between someone who knows how to inject someone who's actually good, and then someone who's really good or excellent. And I think that if you're excellent, you can give results so good that the client and yourself can see the difference. You're both really happy, but when they leave, like no one can tell, and even their partners half the time can't tell. So that's hard to do. Because, sometimes I see these results where I'm like, I don't even think they actually did anything, but they're like, oh, I'm a great injector. I'm like,
yeah.
I still want to see results. And that's the trick, right? So there is a nice natural ability to do things, but at the same time, it's tricky to make sure that both you and your clients are getting the results you want.
Well, we see this in there's a lot in Brazil, there's a lot in Turkey, where, it's kind of like going to a fat clinic and like all they do is you go into this fat clinic and they make you fat and you leave. Yeah. That's like what these injectors are doing, and it's like shocking to me. They'll put in like 20 cc's of filler in someone's face, and they'll say like, look what an amazing job I did, and it looks good on Instagram. And patients come and show me this, and I have to explain to them. I ask them like, do you like the size of your head?
Yeah.
And they're like, what do you mean? I'm like, do you like the size of your head? Do you have a good size head? Like, yeah. I'm like, do you want a bigger head? You want a big volumized head? They're like, no, not really. I go, well, so what do you think is going to happen when you put in 20 cc's of filler? Wherever you put it, you're adding volume. You're going to the fat clinic, you're just getting fat. That's what's happening. This is the same thing that happens with lips. You just want big fat lips, like they just add volume. There's no taste, there's no direction, and it looks decent on Instagram, but when you add 20 cc's of water to someone's face, it looks like a mobile tumor. It's like you're just this big water bag walking around. And it's nice that people are kind of realizing how nasty it looks, and they're backing off and they want to look more delicate, because filler adds volume. And so if you're going to do filler, you got to be very directed, very targeted, very precise, and do little kind of contour changes, little shape changes, little additional support for muscle, all these little things that you can do with it. But most people don't have that target. They just shotgun the whole face and blast fat into it, and it looks disgusting.
It is also like depending on their style, like how they're educated, right? Because you have brands where like, you've got like, in order to fix this, you got to put filler here, here, and here, and here, and here in order to kind of fix that. It's like, no, you just need a little bit right here, probably just to kind of, fix that, because it's been proven half the time where, there was this, I'm not sure if it was a plastic surgeon, but it was a physician who ended up, he was taught in order to fix a nasolabial fold, you got to put filler here and here. And he was doing it on all his clients, and he wasn't getting any results. So he ended up doing a study. I think he tested on like 20 or 25 people, and he ended up doing MRIs on all of them. He's like, no results. Like none of them had improvement by doing filler there. So I approach it the same way. I think filler is more like contouring. And I tell my clients that too. I'm like, it's kind of like, makeup contouring. Your tissues have fallen forward. I'm not repositioning those tissues. That's surgery. But what I can do if you have a mild deformity, what I can do is just basically create the illusion that hasn't happened. But, there are limitations. Just because I can fix that today, you may be able to get away with that maybe 2, max 3 times, but you can't just assume that every year you can keep coming back and doing that, because eventually your tissues are going to expand. It's going to possibly, retain that filler, or you're just going to look bigger, and you don't want that. You don't want like a big head. You want to make sure it's like tastefully done.
Yeah, these big heads don't work. And I had a big head walk into the office yesterday. Yeah. Big head. Lots of filler, translucent face, lots of rosacea. That's something that a lot of practitioners don't realize, is that if you fill the face with filler, especially under the anterior cheek, you develop rosacea, because the blood vessels have nowhere to drain, and they just end up engorging. They're inflamed all the time. So they end up with not just big heads, big red shiny heads, big rosacea heads is how it goes. But I am seeing more and more of these people finally coming in now, more than ever, saying, I'm tired of this. My face doesn't feel normal. I feel heavy all the time. I'm puffy some days, and they develop whole jaw lines. It's like, it's crazy. You see entire jaw lines filled with gel, and it's just like, it's gross. But now I think people are coming in and want to be delicate, refined, defined. You know, most doctors are dysmorphic. They don't know how to do that.
If they don't have an aesthetic eye, and if they're just told on like, yeah, I can get you this jaw line. A lot of times, so probably the most common treatment that I do at my clinic is to fix a little bit of a jowling here, right? So that's just basically contouring. I place a little bit underneath, you know, just a little bit, not too much in the marionette zone. If we need to taper the chin, we can. And then sometimes just where the dip is, where the notch is, at that point, like I can just place a little bit of filler right around here, and all of a sudden it just connects everything. You don't need to kind of do the whole jawline. You don't need to recreate everything. Where back in the day, whenever I thought I was good, I was like, oh, we have to do everything. Like, we're going to do it back here because it's going to like tent everything back. And it doesn't really do that. It just creates the illusion. Now, that said, some people do need it if they've lost, you know, a lot of their bone, if they have no masseter and everything's really significantly drooped and they're like, I'm never going to have surgery, then, you know, that's a real conversation. We can say we can do that, but not everyone needs it. And that's it. It's just kind of like figuring out what you can do to achieve the best result possible with the least amount of product. And this is where it becomes problematic for a lot of providers, because they feel that if they're charging, you know, if they're not using as much product, they're losing profit. Right? So that's where they're charging per syringe, and that's where they're charging, you know, per whatever. And they're like, well, I only use like 2.5 or 3 syringes, or I could have like done this in 8 syringes and I could have made way more money. Yeah. And this is where the problem is with the industry, is because people are chasing the money. And, you know, as we mentioned, like the volume clinics, you have that. You also have people who...
call them fat clinics.
Yeah, that's exactly it. It's just a totally different mentality and a totally different view. And at the same time, you know, these people a lot of them are struggling. They're struggling in business. They don't understand the business aspect of the industry. And they, you know, were either physicians or nurses, the worst people in business ever, probably, to try and run a business. And as a result, they spend all their money on ads and everything, and then they realize all their profit's gone because they don't know how to bring people in. Once they're there, they're like, I better sell the crap out of them. Yeah. And instead of looking at...
And they struggled because of that. So I had a surgeon who had messaged me on... social media, was asking me, you know, this patient's coming in, wants this. I think I'm going to do it for her. And I'm like, why would you do it? She doesn't need anything. Yeah, well, I can't really afford not to do it. You know, she really wants something done. And he's saying he's not that busy. And I told him, I go, guess why guess why you're not that busy? I go, because you're doing shit like this. Yeah. This is why you're not that busy. Yeah. You don't have the taste. The other thing I'm thinking about recently is also, are there more natural fillers? And this is in a world where filler is not natural. It's a hyaluronic acid gel that we're putting in the face. It's not your own hyaluronic. So it is just not natural. But it can kind of behave and integrate into tissues. And do you have a preference of fillers when you're doing stuff in certain places, or ones that you don't want to use because you don't think it kind of falls into the tissues around it in certain places?
Most of the time it's around the eyes and the lips, obviously. Well, it depends. Anything that's like a constrictor muscle, then you have to be limited, right? So if a client comes in and they want, let's say, tear troughs to be rejuvenated or whatever, they want to be improved. At that point, you know, first of all, you have to see, are you interested in dermal filler, HA filler? Because a lot of people now are kind of like, you know, HA filler is the devil and they don't want anything to do with it, until you have like maybe a conversation with them where you're using a minute amount, and if it's done tastefully and if they're candidates, it's actually okay. But still, there are other options that you can use, such as like the PRP or PRF, and then now you can do like PRF or PRP gel, and you can do that. You might not quite get the results of the immediate satisfaction with it, but at the same time, you're improving the skin. You're also stimulating collagen. It's as natural as it can be. So you're getting a nice, you know, gradual improvement. That means they'll probably have to come in 2 or 3 times in order to get some type of mild improvement, which is totally okay. But it just means there's a little bit more upkeep with it. So it just depends on what they want, right? So some people are like, oh, listen, I don't have time. I just want quick fix and I want this done now. And if they don't have any seasonal allergies, if they don't wake up feeling puffy in the morning, they're not, you know, drinking alcohol the night before, or like sodium, and then they wake up puffy, and they never have any issues around the tear troughs, then I'll let them know, yeah, you're probably a candidate. But even then, it's not a guarantee with HA filler. I'll just let them know that's a good chance that as long as I'm not overloading your lymphatics and I do tastefully, you shouldn't have an issue. And for the most part, people won't have an issue, and it looks amazing. But that said, for some reason that's just like an anatomy thing where some people will come in and I'll do a little test on them and I'll be like, I don't think you're going to get that great of a result. It's just like, it depends on how the tissues lift. Sometimes I'll place, dermal filler underneath the tear trough here and I'm like, oh, you got like 20-30%. I'll do the exact same thing on someone else and they get like an 80 to 90% improvement. So it's everyone is different. It's our job to kind of analyze who are going to be great candidates to end up having great results, and also it's our job to respectfully listen to what they want, and if we have other options other than hyaluronic acid, then we can use that. So yeah, hyaluronic acid for on the tear troughs is okay in moderation. If you're going to go more natural route, I really like the PRP gel or PRF gel or whatever you want to call it. And for around the mouth, same thing. Like basically, I think if you're looking to volumize the lip, hyaluronic acid is still probably the best one because you're going to have volume at the same time you can dissolve it if you're not overdoing it. But if you're looking for a little bit of hydration, maybe kind of let's say just, I don't know, it's like the je ne sais quoi, right? You're just kind of like stimulating a little collagen.
I don't know what
redness.
That means. I don't know what.
Exactly, I know. So if you do like a little bit of PRP or PRP gel or anything around the lip or anything like that, it definitely helps with skin hydration and it gives them kind of like a little bit of a natural hydration. But that's basically what I'd use around the mouth and the tear troughs. For the rest of the face, again, like you can use hyaluronic acid. I'm okay with sculpture. I'm okay with using hyperdiluted radius, but there are a little bit more risks with regards to where you're placing it based on how tight the area is and also how much constriction there is in that area.
Yeah, I think the main issue I see with natural versus non-natural injection is imagination versus reality, which is like, you wouldn't think that, because everyone assumes they think about anatomy, but realistically they don't. They're just thinking about how to alter a face. So they look at the face and they just start thinking about how to alter it. They're not like thinking, okay, what's actually inside of that face? Where can I add this volume? In what layer? Am I under the muscle, over the muscle? They don't go that far. So they start to come up with imaginative ideas of how to change things. Have you noticed in the world of the neurotoxins any kind of trend towards naturalization or any kind of changes recently?
What's nice about living in Ottawa is that we're a very conservative town. So most people want natural. It's not rare, but it's less common where people come in like, I want to be frozen and I want to only come back like twice a year to get this done, so just try and blast me as much as possible. And the other thing too is, even with neuromodulator, we talk a lot about dermal filler and stuff like that, seeing like good work with dermal filler. You can tell who's a great injector, based on who's done, like, oh, who did your work? That's actually really nice. I start seeing that now with neuromodulator and more or less with younger clients. Because
so they don't look like
well,
this
it's
when
not
they're trying to move their face.
So for some reason they just get it done, but it ages them because it drops their eyebrows, right?
Very much.
Like drops their eyebrows. Their lips are a little too done. For me, neuromodulator is really particular when it comes to like obviously the frontalis and the lower aspect of the crow's. Those are the two places that's going to kind of mess up your face because it takes away your Duchenne smile and also drops your eyebrows for the most part. And if you're not sure how to shape it, then it just basically ages you. So I see girls now who are are servers, and I'm like, how old is this girl? Like, she 32 or she 22? I can't really tell. And then she's like, I'm 21. I'm like, oh my gosh, like what's going on here? Like, how did you go from 21 to 32? And they are using neuromodulators. It's mostly the neuromodulators' fault. Their lips are a little overdone, but it's just kind of like
buccal fat removal.
Yeah. It's and in Ottawa, like that's even buccal fat removal is definitely even more rare. But it's just those little things that if you can kind of tastefully do it well, then obviously, So for me, with neuromodulators, less is more, and it really does depend. The big ones are going to be here and here, and if you can kind of understand based on how much movement there's going on here, how much they're going to drop. Some people, there's no guarantee either. Some people think, oh, just because you're a little bit more mature, like you can't give them this dose. I've had clients who are like 55, 60, I'm doing this and it's tight, like nothing moves. I'm like, what the heck is going on? This is amazing genetics, and I could just give them 20 units and they're stiff as heck and they're happy and nothing drops. But most people, whenever I'm doing that, even at 35, 40, I'm limited to going more than 6 to 8 units on the frontalis just because I want to make sure that they have some natural movement. It keeps their eyebrows nice and perked, and it's just making them look refreshed, which is the whole idea.
And are you doing micro technique or non-micro technique? Meaning, are you doing sub 1 unit injections or 1 unit injections or more?
It depends on
And
where
at
you're
what
placing it,
layer?
right? So for me, it also depends. It's a great question. So when you're looking at neuromodulator, right, if I'm going to be doing the glabella, right? So if I'm looking at the procerus, I'm going to go deep. I'm looking at the corrugators, I'm going to go deep at the belly. But as I move, laterally, I'm going a little bit more superficial. Whenever I'm doing the frontalis, if I want to not drop them, but at the same time they have like these wrinkles right here that are just above, then I'll go intradermally. I'll place probably 0.5 to 1 unit, and that will help a lot of those little commas they call. But whenever I'm going higher, I prefer to go deeper into the muscle if possible, and but I still do low doses for the frontalis. Like I do all 1 units basically.
Yeah, me too.
And I find it works great. It's even distribution. I'm not a big fan of like the 5 units, 5, 5, 5, 5, 5. I'm like, what are you talking about? Like they have wrinkles down here. All you're gonna do is just make them super heavy, and you're not even addressing the area of concern for the most part. So there are areas where you can kind of like place heavier doses, but that's the finessing of neuromodulators, is just kind of like figuring out where it takes microdoses. Like here, microdoses. Like for sure, I just do 2 units right here, very superficially, max, and that's it.
Same. You can change someone's smile very quickly.
Yeah.
You can drop their smile if you hit zygomaticus. You can impair lymphatics. Another thing that like is very common that goes undiagnosed is impairment of drainage there, because you don't have the
That's right.
blink flushing or the flexing of the malar basin. So it's like,
right, you have your lymphatics that kind of go like
it goes all the way around,
and then it goes down. This is the area why people end up having like that's why you see people who do like these lymphatic massage clinics. They've never even had Botox or filler, but they go for it. It's just a genetic thing. Like we all have issues here, and some people have it more than others. But if they already have those issues and you're blocking it with a muscle constrictor or adding filler,
and then adding filler on top of it,
then you're getting issues. But it's funny because I do see these like top injectors who are all on social media. They're like, I was trained never to do Botox under here or neuromodulator Dysport, but look at me. I'm like not only around there, I'm in the eye, girl. I'm like, okay, so they're just proud of doing all this neuromodulator here. And yes, it might help people who have mild crepey skin here, but you're messing up all the contraction. It's the only contraction that's left around there that you're asking for trouble. And you can't do that on everyone either. Like even if for some reason they end up getting a good result and it didn't affect their lymphatics, like if people think that this person had it, they're going to be like, I want this, I heard that I can get that. I'm like, you have such loose skin there that if I do that, it's just going to hang over.
Yeah, so I think same with fillers. Most doctors or practitioners don't understand the why they're doing it. They're just getting creative of where to put it. They don't think, why am I Botoxing this person who's like 20 years old and not Botoxing this person? Or why am I Botoxing a 60-year-old and not a 10-year-old?
Yeah.
Like they don't think about why. What's happening that the 60-year-old needs it, the 20-year-old or the 10-year-old doesn't. They just skip to, there's the face, let me just start messing with it. When you start to think to the why the Botox is even needed or the toxins are even needed, you start to get more directed at where you're going to put it so you can relieve the problems that are happening with age. And address it other ways.
What I liked about your Cupid Compendium was, man, I was taking the courses. It's great. So for me, I've been an advocate for telling people, I think the reason why I became successful in this industry is because for the first 6 months, man, I never took a course. I just kind of learned it on my own, but in my own way. As in, like, I bought some books online. At the same time, I took some cadaver courses that I could find through PubMed, and then also research, kind of figuring out how the face aged. Like, tried to memorize as much as possible all the facial arteries and where they changed in depth, which is kind of like, disproven now that, we see all these ultrasounds and MRIs, kind of like how they vary, but also like where the fat pads, where they change, and also what's happening with the skin as much as possible. And then after that, that's whenever I took my course. And whenever I went in, the guy who was doing the training, he's like, dude, your questions are crazy. He's like, how long have you been injecting for? I'm like, I've never touched anyone yet. He's like, holy cow. But I told him right off the bat, I laughed, and I'm like, I'm going to let you know. He's like, it's going to sound hilarious, but I'm looking to be the face of Canada. He's like, they all say that. I'm like, I know. But then after that, he saw me in Paris like a couple months later. He's like, damn. He's like, okay, you're serious about this. I'm like, I'm dead serious. But it's because I took it seriously, and I understood the basis of anatomy. And what happened was, because I felt really comfortable with anatomy, and also not only anatomy with injecting with a needle, I was like, I got to get really good with the cannula because it just makes it that much safer. And it's also less bruising for the client, the whole bit, right? So once I understood that, I was like, okay, well, man, I could actually treat the forehead. I could treat the temple. I could treat certain areas of the face that people aren't going to treat, as long as you understood the anatomy and how to avoid blocking that artery, and also like, certain techniques to really pretty much almost get to zero. Like if you can do this with almost zero chance of having an issue, then you can do that. But the rule is for now still, like for some reason, it's like, oh, you can't do that because you haven't been injecting long enough. It's like, what happens if I could tell you why, this won't happen? They're like, no, the rule is like it's 3 years or something. I'm like, what? Like,
yeah, that's
the
crazy.
person who's 3 years, can they tell me why what they're doing is not going to cause an issue? In most cases, they can't, right? And it's because these people, the trainers, are just like, they're morons. These people are just doing it for a long time, and just because you've been doing it for a long time, they think that they can train people. So with your compendium, what I loved, man, was that I was like, anytime that I go to a conference now, the first thing I do is I just try and get to the cadaver lab, and I try and get to see what this surgeon's talking about. But I feel like they skip over a lot of stuff. They skip over the stuff that's important for me as an injector. Like what I loved with you, man, like your buccal fat. And for me, I thought buccal fat was just here, but you're like, no, buccal fat goes all the way up into the temple, and this is where you should be injecting. And one of the ways that I inject the temple is a deep fascia or interfascial technique. But the one thing that I didn't like about it, the way I was trained, was I was going parallel with your deep and superficial temporal arteries, and I was like, oh man, it's a little risky. So I'd use like a 22 gauge cannula, but you're like, no, just go perpendicular, go on the side, and you're just going deep. And it was cool because you were placing it, but I was like, how the hell does he know if he's actually in the placement? And then you opened it up and you're like, here, I'm going to show you, this is all the placement. You showed all the layers. Video. Yeah, it was great. Yeah. Honestly, it was great. It was a terrific video. That's exactly what I'm hoping for. And I took so much out of that video just from that, and also you kept going. Like you opened it up, you show the tear trough, right? So for me, one of my main questions whenever I'm doing the tear trough is, why is it that, for you like, whenever I'm injecting with a needle, if I ever go a needle, like you go right on the periosteum, you can feel like a little ridge almost, right? That's like the sweet spot to kind of like place it. But the problem with the needle is that they bruise. So I was like, okay, I'm just going to do the cannula. But then after that, like
there's more backtracking.
Yeah. Now the thing is like whenever I was learning the other cadaver labs, it was basically their show like, listen, you've got skin, you've got the orbicularis oculi, and then underneath there's not much really there. Like you're just going into the deep medial SUF. But I was like, I don't need to go into the SUF. So I was basically placing a lot of my product just under the flap of the muscle. But I always wondered why you were jamming yours up against the bone, and then after that you kind of did a little bit more of a superficial technique where I was like
immediately
immediately, right? But so it was great because honestly whenever I looked into that, you really explained the flap, you understood, you kind of were saying like, listen, if you end up placing it all superficially here, yes, it's superficial, but at the same time if you place it all superficially, it kind of just slips for some of the people.
As you sit up it goes down and you get chipmunk cheeks.
Yeah,
gravitational descent.
It was great, and then you go on to even more with regards to the deeper layers of the buccal fat. So for me, I think the cubic compendium is like genius for two reasons. First of all, you really focus on the anatomy, which is like that's for me, and anyone who's getting serious into medical aesthetics as an injector, you have to get super comfortable with knowing as much as possible about the anatomy, which means like it could be totally a different way for you, but for me I have to learn it my own way, and until I can learn it and do all these little things until I kind of get it, then at that point then I'm comfortable going and doing the injections, and as a result I'm comfortable doing multiple areas on the face, and now I do everywhere on the face and I feel like I do it pretty well. Where a lot of people who are in this industry, they're like, I don't do the nose, I don't do the forehead, I don't do the temples, I don't do anything because it's just too risky. I'm like, well, like take the anatomy, figure out what you can do in order to mitigate the risk, and
on the contrary, people inject in risky places. So this is, I will close with this, telling everybody the don't be naughty rule. This is injectables. Instead of getting creative and think about spackling the face and pulling the rubber and the thread and all these weird things that people imagine, those are naughty thoughts. Those are naughty thoughts. Go back to the anatomy. Learn the anatomy, and when you learn the anatomy, you'll understand that there's only a few ways to manipulate problems that happened, because there's a specific issue that happened, you fixed a specific issue, and beyond that, you can't alter somebody that much. Very, very little. When you know the anatomy, you see it from the inside, you don't have this imaginary thing where you take someone's lip from this to that, you start to see the confined space that you're injecting in, and when you know the anatomy, your risk doesn't become, maybe I'm going to inject a vessel, it's I'm never going to inject a vessel. So don't do naughty things. Don't do piriform injections with a needle. Don't go with a needle straight down in the fossa over here. Don't go with a needle into the forehead. These are naughty places to inject, and you can get vascular occlusion. And you should not accept a 1 in 1,000 or 1 in 100,000 chance of blinding somebody or 1 in a million chance of blinding somebody. You should only accept 0, and you can only do that with the anatomy. So we'll end this segment on natural filler, but that is on the Cupid Compendium. Hopefully you guys all watch it. The world of biostimulators is a world where we inject things into the face and get your body to do all the work. Your body starts to create things and do things. The most popular, I think, and long-term kind of used biostimulator on the market, like actual product, is probably Sculptra, poly-L-lactic acid. Do you use that a lot?
I do use it a lot. Clients come in and they really don't know what the difference is between HA filler, Sculptra, so you just have to kind of like let them know that basically the breakdown is we're coating the face with these very, very small particles, and each particle is going to make collagen around it, but it's the collagen is a little different, right? It's still type 1 and type 3, but the amount of type 1 and type 3 is a little different. It's almost as natural as it can get, other than using like your own product, which is PRP gel. But the benefit of the Sculptra is that you're going to produce more collagen, which means you're going to produce a little bit more volume, and it's going to last a little longer. You can't quite shape the face of it like any other type of like hyaluronic acid filler or maybe Radiesse or something like that, where you can kind of basically shape, but at the same time what's nice is it kind of stimulates collagen in this more blanket approach, and you can kind of use it similarly to HA filler where you can do some contouring, right? So like if they've lost volume, if everything's shifted forward here and you're like, okay, well you need a little volume here, we can coat here in the marionette zone, as long as it's not too close to the mouth. Like you can also do a little bit here, which will create a nice little bit of volume, and also in the nasolabial fold you can do that too. It's nice because you do everything with a cannula, usually really safe. And it's this nice natural treatment. Now the thing is, it's not going to give you perfect results for the most part, but at that point, that's whenever you let them know, like, listen, once we've achieved the amount of volume that I think is, maxed out, because some people don't think that you can max out with Sculptra. You can totally do that. Like if you keep pushing your face out, you can get a big head with using Sculptra too.
Yeah, of course.
It's not necessarily puffy, like it might not feel water baggy like hyaluronic acid, but at the same time, you can still kind of get a big head. So we want to avoid that. And right whenever we find there's a sweet spot of where you've restored that natural volume that's lost, then I'll go ahead and I'll just let them know, hey, by the way, I'll just take a little bit of HA if you're up for it, and I'll just kind of like fine tune a couple areas just to kind of like make it perfect. And that's how I use it. I'm not sure if you use it, and if you do, like I always wondered how is it different than fat transfers, and is it similar? I know that fat transfer is obviously completely natural,
so it's better to think about it like a fat transfer in a way rather than collagen. Because collagen is like saying this is carbon, 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 CO2.
Yeah.
Those are all carbon. So and it's very different. So I don't even say collagen because it doesn't have a translation to the reality of the product that's in there. Because it doesn't matter type 1, type 3. The arrays matter, the organization matters, and the building blocks. The smallest building block of collagen doesn't matter. It matters what it forms. So I never use collagen in there because I think it's sort of misdirecting practitioners and what it does and what it is. But when you mention fat, then I'm like, yes, now it makes sense because it mimics fat.
Yeah.
And that is exactly what it does. And when you think about the indication of HIV lipodystrophy, fat loss, and that is what it was mimicking. So yes, it's a little tiny particle that goes and irritates the body to eat it up, and while it does so, it deposits fibrotic granulation tissue around it, which has collagen in it, but the idea is that it makes these granules, and these granules are super, super useful for volume loss in areas where you have diffuse volume loss, because you can spray it in there, and your body will go start to eat it up, and it'll start to form granules. There's no situation where it doesn't form granules. It's like that's kind of what it's a particle. Your body eats it, it forms a granule. It doesn't go in there and stimulate collagen restoration of dermis. And when you say collagen, really what we're thinking about is dermal collagen. For the most part, is the structural integrity of the dermis. Elastin, same thing. Elastic, structural integrity of the dermis. Hyaluronic acid, both actually dermis, subdermis, fat. You have hyaluronic in all of it. So when I mention Sculptra and talk about Sculptra, I'm always thinking physically in the fat world to say, where did I lose fat? How am I going to replace fat with Sculptra? And it's a little firmer than fat, but not that much. Like, so it's like a little firmer than fat, a little stickier than fat in terms of its adhesion to the surrounding cells. So when I use it for like my most useful places are two places: deep temporal fat pad and buccal fat. And those are the two areas where you have this fat that is kind of lost. It's hard to replace. You could put a gel in there if you want. But sometimes I like putting Sculptra, and I'll go put it, fan it around in there, and wait a couple months, see what happens, because you don't know how it's going to react on one person versus another, how much volume it's going to make. And I never mix it with anything because you don't, again, it kind of changes the reactivity of how much your body is going to deposit of these granules. It's not fully predictable. It's not a one vial gives you 2 cc's. It doesn't work like that. It could be 1 cc, it could be 5 cc's, depending on how your body reacts. But that's how I use Sculptra. Versus like calcium hydroxyapatite, I don't use it as a biostimulator because it's also a calcifier. It like puts calcium in there, if you do it dilute or not. And I just have, that's my own issue where I have emotional trauma from, people have generational trauma. I have like emotional trauma from being in a phase and it's crystallized and you hear the cracking. And when I hear that, I just think like, oh, it's like the soft tissues are supposed to be soft. So that's the reason I don't like that. Then, so that's that kind of biostimulation. Then I think about the other kind of biostimulation where we're actually just stimulating the body for damaged tissues, which is totally different. So I think about biostimulators in those two ways. We have volume loss, and then we have damaged tissues. And damaged tissues could be the dermis, so layer 1. It could be layer 2, being the fat and the subdermal fat fascial layer. It's fascia in some places, right?
Yeah.
And it's fat in some places. So both of them can get kind of dehydrated and damaged. And then layer 4, which is going to be your subsmass. And that's what I think about. Those are the two layers, really, layer 1, 2, and 4 that I'm thinking about for biostimulation, where I want to inject something to regenerate or fix damaged tissue. And then we're doing PRP, PRF, Easy Gel, which is a kind of a combination, and it's a brand product of how to mix it, and nanofat. And nanofat for me is like, and exosomes to some extent. Nobody knows. You're not supposed to be injecting those, but let's just say scientifically you're thinking about what it does. Maybe it has some regenerative effect too. But nanofat most certainly does. PRP mildly does. And PRF has this other cool, weird biomatrixy effect where it does something hydrationally. So I always categorize into those two things. And the stimulators like nanofat and stuff, I don't think about deep temporal fat and buccal fat. I think about volumizers. So HA, Sculptra, fat grafting. Those fall into one category. And then calcium hydroxyapatite for me falls into no category. I think it's useful for dentists or people who have like little bony defects and you want to add a little paste and try to calcify that area.
Yeah.
I think it might work. I have trauma for other stuff just because I'm a surgeon. I'm always cutting into stuff.
Yeah.
And then I have the stimulators. And I think the stimulators are just phenomenal in all situations. Like you can just use them pretty haphazardly because there's not much bad that happens, except for vascular occlusion you can get with like nanofat. But otherwise, you just kind of put it into things and it makes it better. It's a weird magical solution or potion.
So for you, because I have clients who come to see me and they're like, hey, by the way, I've been told that Sculptra and Radius and all these things, that's creating scars.
Yeah.
And they're like, I don't know if I want to get that done because it's creating scars. And at the same time, we also have some plastic surgeons who are saying like the only thing you should do is, facelifts and fat transfers. And
that creates scars too.
Well, that's exactly it, right? So I mean, what's your answer as a facial plastic surgeon? My two questions are, okay, clarify what this scarring means, okay? Yep. And at the same time, these products are, on average, they say they last, or the volume that's going to create, whether it's collagen or scar tissue, whatever they're creating, is going to last about 2 years on average, okay? Do you feel like as a plastic surgeon, do you think 2 years is a good average and there are outliers? Or are you thinking like, no, it's like 3 to 5 years and then there are outliers that are going to have it less or more? No,
so that's a absolutely like incorrect assertion. If somebody says that you inject Sculptra and it's going to last 2 years, it's a really stupid thing to say. Like
that's what the
product
monograph says. The thing is like, how can we know? Because we would never be able to go inside. That's what I'm asking the surgeon.
Well, also just think about it. Like, how long does a granule last?
I don't know.
Exactly. That's the answer. I don't know. And you will never know because it depends what your body wants to do with it. most people's bodies, when they form a granule, they'll keep them there. Okay, some people have a hyperfibrotic phase in healing, and for them it gets firmer and bigger for the first year, and then it calms down afterwards because their inflammatory process calms down. So it depends on their immune system. You don't know what it's going to do.
Yeah.
There is zero way to predict what it's going to do in any individual person. So you can never say it's going to last. The only safe assumption is that it's going to last and maybe it'll grow. That's the only safe assumption. So you just assume that it's all going to last and maybe it'll grow. As far as like repeating injections, give it 3 months, like give it some time before you keep adding on. It's always a good idea. But as far as like what scar is, you have fibrosis, fibroplasia, fibroblasts, right? All this fibrous stuff. And it depends where it is. If it's in the dermis, it could be hypertrophic scarring. It could be atrophic scarring. You could have keloids. If it's going down a layer deeper, you could have just subdermal fibrosis. All these things can happen. And they can happen from surgery. They can happen from injections.
Yeah.
What they don't happen with is nanofat. So nanofat, PRP, PRF, they do not cause that. They actually soften tissues. It's very interesting. They soften tissues. That's what they're used for. If you have scar contractures from burn scars, the way to release it in many cases is to inject nanofat PRP, and it starts to soften it. It's anti-fibrotic. Surgery is pro-fibrotic. Sculptra is pro-fibrotic. So those things are pro-fibrotic because they're working in a different inflammatory process. And they are in inflammatory processes. These are anti-inflammatory processes when you're using PRP and this and that. So you do cause a bit of inflammation by the influx of the immune cells, but the immune cells are there to heal things rather than to eat things and build things. So it's a little different how they act.
If you're placing your Sculptra deep, right?
Yeah.
If, let's say you place it in the right plane, in a nice open subcutaneous, you can either put it in deep fat or superficial fat, whatever you want to do, but it's in a safe plane.
Yeah.
And that's where the area you want to target. You're injecting that with Sculptra. Do you think that area is going to cause chronic issues for the surgeon, like at any point in their life? Are they going to come in and be like, surgeon, like, this is going to make my life difficult for them?
It's always a little stickier.
Yeah.
But same with doing Ulthera a bunch of times, same with doing surgery a bunch of times.
Yeah.
So it's always a little stickier. I mean, you're a bad surgeon if you can't get through it. It's like, it's not that big of a deal.
Yeah.
If it's placed in the right place. If somebody has, most people who don't just do Sculptra, they'll have like 50 things in their face, and then you go in, and it's kind of hell territory. But for the most part, it's not a big deal. If you have Sculptra in the right plane, being sub-SMAS or super-SMAS, maybe it bleeds a little more, maybe get a little more adhesion, but so is a revision facelift. So it's not tremendously different than that. It's really when they mix it with like calcium hydroxide. Calcium hydroxide is hell. That's pure hell in soft tissues.
It is, yeah.
It is hell. It is. You can't even get through it with a knife. It's congeals everything, and it makes it like white, and it's crystallized. And you can see it in videos like all over the place.
I can feel it whenever I'm trying to go with Caniff.
You're stuck. Yeah,
I'm just like, oh my gosh.
And you can't even inject.
I can't tell what plane actually I'm in because I'm like, am I in the muscle? Like, it's that tough.
Yeah, but Sculptra's not that crazy. Sculptra just gets firmer. There are situations where it does get ropey and does get firm for the first year, and you have to inject it with 5-FU to off-label to calm it down, or PRP. But for the most part, it's pretty good. When I think about it that way, where it's like volumizing biostimulation versus softening biostimulation, I kind of keep myself in check, and like if I were to ever go back into a face after I did thinking about it that way, I never caused problems. Yeah. Because anatomically it just kind of made sense. But I do like to tell people, get away from the whole idea of collagen. Because like collagen, think about it, it's really for dermis. Yeah. So when we talk about collagen, let's talk about microneedling radiofrequency, talk about lasers. That's collagen. That's like, you can show that histologically. You can show CO2 going deep, causing coagulative necrosis, and doing these kind of things, and that's collagen. So that's a collagen discussion. I don't think Sculptra is a collagen discussion. I don't think it ever should be. It doesn't make sense because the macro of it, again, carbon. Yeah.
It's just, you see it as a volumizer, really. And
it is a volumizer.
Do it. Yeah, I see it as like, basically for me, when it comes to there's a volumizing biostimulators, and there are non-volumizing stimulators, and that's specifically usually for the skin, and that's how I kind of like see it as well. And that's how I kind of like differentiate my clients, because sometimes like, well, should I do Sculptra? Should I do microneedling radiofrequency? Should I do exosomes, or should I do polynucleotides, or should I do like radius or something? I'm like, wow, these are totally two different things. So what's nice, I'm a big proponent for microneedling radiofrequency. I think there's obviously limits on how often you can do it, but it's a great way. Like, if someone were to ask me, well, what's the future? I'm like, if they could figure out a way to produce more elastin or focus more on elastin than just the collagen. I think collagen is like
all of them. Hyaluronic, collagen. Yeah. Collagen people focus on because it's a keyword.
Yeah, that's right.
It's a keyword.
Like, just what about elastin? Like
elastin, telomeres became a keyword.
Yeah.
And there's no causation with it. Okay, but lesson for everyone at home: don't listen to anything you hear from either of us or anybody outside. Everybody's confused.
And that's it. It's funny because you're going to go to this conference and people are going to say completely different things. And a lot of the times, unfortunately, in medical aesthetics, it's because a lot of this stuff isn't peer reviewed. Like when it comes down to, your top 5 peer reviews, like the top 2 are usually the ones that are like, you have your meta-analysis, you have all these top. There's none of that in Botox and fillers or anything like that. It's all just based on a show when they're on stage. And people who are new into this industry are kind of confused because they're wondering, like, should I introduce this? Yeah. Which is where I kind of like, I don't know if polynucleotides are actually doing anything.
Yeah.
I know.
So if there's different, here's another thing. So if there's no consensus and everyone has different opinions, it means one person's right or no one's right. It does not mean that everyone's right. That's the big takeaway where they say there's so many different ways to skin a cat. No. There's like one really good way or you haven't figured it out. That's how it is. All right, so we'll leave you with that on the biostimulators.
All right, chat a little bit about the Cupid Compendium course, which is amazing. Now you've got a conference coming up. I want you to tell me a little bit about that and how this all came about, because I'm sure the Cupid Compendium, the conference, all kind of relates. I want to know your vision and why you're pushing this.
The Cupid conference, Cupid Compendium conference, we're going to have here in LA. It's going to be a 2-day course, kind of combining an anatomic kind of principles for injectors and surgeons. And I think it's super important because surgeons suck without knowing anatomy for injectables, and injectors completely suck without knowing anatomy for surgery. Yep. Like you have to look at both, do hand in hand, and we don't want to separate out, do an injector's day and a surgeon's day. I don't think there's any difference. There's major contributions from volume loss to aging, and we have to like really address those and look at the function of the muscles, the function of the face. So my idea was to make a conference based on this, where we're using not cadaveric anatomy, really surgical anatomy, where you're in the planes that you're dissecting as a surgeon. It becomes helpful for injectors to understand how to advise their patients how it may affect a surgery, and they can see the actual anatomy of what they're injecting. Yeah. And then surgeons can see externally how to approach these things volumetrically. So we're bringing those things together. And we had a Cupid conference last year called the Perioral Aesthetics one, or for perioral beauty. And we were working just on this area because we're Cupid Lips. Yeah. And we're doing, we brought together dental practitioners, orthodontic, orthodontic, and plastic surgery, facial plastics, cosmetics, all that, together to understand the mouth. Now this one's going to be full face, 2 days of kind of didactic lectures and a lot of surgical videos to show anatomy and run through things. And I think it's going to be really helpful, kind of like the Cupid Compendium. The whole idea is to bring in the surgical view for the injector. That was the original view, just to really like get injectors to see the anatomy, understand it better, go lower risk on everything they do, more directed at everything they do. And then it became something where I wanted to go the other way around too, where I wanted surgeons to really understand the injection techniques and the volume. So this conference is for that.
I love it, man. So it's interesting because whenever our clients, come to me, one of the most common questions is, how the heck do all these celebrities look all jacked up from these plastic surgeons who they're going to, who are doing these injectables? And I think it's, for me, it's because, like we mentioned before, where are you going to go in order to get quality injectable training? Like, you're just guessing. You're guessing to someone who's been doing it for a while, and hopefully they fit your style, or hopefully whatever style you're learning from them is going to actually like relate to your practice and ends up doing you better. But if you are training with someone who is a terrible injector, and they're basically relying on their skills as a plastic surgeon, which is still amazing, but at the same time they didn't take any training on how to actually do injections or Botox or filler or anything like that, then that's where it gets complicated, because people assume that if you take plastic surgery or dermatology they're teaching you about Botox and injectable fillers in these courses, and for the most part, they're really not. Unfortunately, these courses are usually all private, and it's just from some guru person who's showing you how to like do stuff.
They all call themselves anatomists.
Yeah, exactly. Well, that's it. So what I love about this is, your program is based on you combining your skills as a expert facial plastic surgeon, understanding your anatomy, and also bringing back your expertise as an injector before this, because you used to like just inject a ton of people all the time, right? And not only that, I'm sure since you've injected, you've improved your skill based on the fact of how well you know the anatomy. And now you're like, okay, let's combine these two, let's make it work, and let's sure that not only plastic surgeons are injecting their best ability, but also other injectors who are going to say like, listen, this is you're coming to a safe place. You're coming to an area where you're going to have a compendium. Your compendium is going to have probably CME credits. I'm sure you're going to have all these other
working on all that.
That's right. So it's a terrific platform where I think it's super unique in the sense that instead of just guessing if this is going to be good, this is going to be good. And I really like the style of your injections. It's very similar to my style. There's no codes. There's no like kind of whatever. It's just based on what can we do in order to enhance things to make it look natural, but to another level because you understand the anatomy so well. And I've already learned a ton from taking your anatomy courses online. I can't wait to see what this conference holds, man. This is going to be great.
Yeah, so we're gonna start promoting it soon, and then for everyone at home who wants to sign up, we're probably gonna do some early bird stuff, but it's gonna be a very intimate conference of 200
Join
people.
the wait list, people. I'm telling you, it's gonna be packed, and it's
at the Edition Hotel in West Hollywood.
Oh, there you go.
With parties.
Of course, I'm telling you, I'm very much looking forward to it. It's been a while since I've been looking forward to going to a conference that is not just a show. It's a legitimate course where I'm going and going to bring my game up another level, which is awesome, man. I'm looking forward to it.
I'm glad you're coming.
Yeah.
It's going to be a bunch of people like us. Nobody talking about dumb shit like you see at other conferences. That's going to be the whole motto for the Cubic Compendium Conference. Nobody talks about dumb shit.
That's right. Listen, do me a favor. There was a clip that I heard from you probably 3 years ago talking about injectables, and you were talking about the pyramid or the three pyramids of the face, and I've been doing so much research to try and figure out what the heck you were talking about, and I can't find it. I'd love to know what you meant about that. Break it down. How it can help me maybe as an injector.
All right. Well, there's two I can think of. So one is the structure of the fat cells in layer 2.
Okay.
They are size-wise, they come out in a pyramidal shape, meaning the fat cells in what we call the hypodermis, which is the reticular dermis.
Okay.
If you look at the reticles, like the reticular parts of it, there's baby little fat cells that sit in the nooks and crannies of it, and as you come down, the fat cell size gets bigger.
Okay.
And this is important to know because you always have to integrate whatever volume you're injecting to the size of the fat particle that's there, or else you get irregularities. So let's say you go directly into the reticular dermis, hypodermis, you have to have baby fat cells, really, really small. So you'd have to have a filler, for example, that's going to be as small or smaller than those fat cells. You can't go bigger. As you go deeper, you can do bigger fat cell sizes, or let's say Sculptra, and we're using granules. The granule has to be smaller than the granule or the fat cell size that's there, or the same size, or else you get a mismatch and you get bulges. Okay, that's why it's not smooth.
Yeah.
So that's one. That's the one thing when you look at the pyramidal shape of the fat cells in that layer 2, it's important to realize that. And this is on the thicker parts of the face. The thinner parts, like around the eye, just have fascia, not fat, because it's a fat fascial layer 2. Then there's the pyramidal buildup of the cheek. From front to side, and most people understand there's a general pyramid there, but they don't understand like what the importance of it is or the significance. When you look at aging of the face and pendular or descent of the face, you have two types of pendular descent. You have one which is in the glide plane, which is layer 4, so subsmass, and that's this one. So as you lay down, it glides back. As you go forward, it droops forward. Not infinitely, because it's an areolar plane. It's not a glide plane. It's an areolar fascial plane that goes this much down, that much up. So it shears. So this is gravity's effect on your face. Why you look better when you lay down, and then you look worse when you lay up, right?
Yep.
There's a second, and this is pendular, but in the XY axis. Then you have the Z axis pendulum, which is going to be the pendulum that you have as you lose volume and skin support, as well as skin rigidity. So if you see a baby's face, it's filled out all the way, fully and has nice structural rigidity, when you lay them down and you sit them up in the cheek, there's no change. It just stays exactly the same. On an adult, you deflate and you come down, and everything starts to deflate down this way, away from your eyes to the lower cheek, right? And you start to get these pores and rhytids going in this pattern, just like that. You see those? Those are not something that you can lift. Those are volume deflational patterns of rhytids. So when you're reinflating the face or volumizing the face, you have to think, okay, how am I going to restore support to this skin in a way that's not going to be affected so much by gravity? This is the tricky part.
Yeah.
The more you stick to the bone with a volumizer, the more it's going to have no gravitational effect on it. The less gravitational effect is on it because it's stuck to the bone. So if you go up and you stand up, you go back and you stand up, it doesn't move, doesn't droop down. The farther away you are, meaning towards the skin surface, going from layers 5, 4, 3, 2, 1, you're all the way out here. If you lay down and you inject at that skin surface and then you sit up, it falls down. So you get more pendular descent in this direction. So when you're building up the face, you have to realize that. And that's why when people do all these superficial under eye fillers here, they get a chipmunk cheek because they sit up and it ends up right here. It started here when you're laying down. But then they sit up and it goes like this and it comes down. So when you're doing restoration of this area, you have to be cognizant of that. And then you start to work three-dimensionally from the front of the face to the side of the face. There's a corner here on your face. That corner, which what we call the deep plane entry point, is the junction of the muscle to the fascia. It's also the front of your face to the side of your face. Here you have one called conjoint line, superior temporal line. It's from the front of your head to the side of your head, right? So you have to work from front to side three-dimensionally, understanding the face. When you're dealing with the brow, for example, if you have deflation in your deep temporal fat pad, you lose your lateral brow projection. It goes back in. Face is the same thing. It starts to go in this way, even though you're getting deflation this way. So you have to always align things from the front to the side. But most people don't do that. They just see front, they see side, they don't connect them. And you want to go from bone deep, okay, superficial last. First start up high, then move down low. This is the pyramidal approach to it. To say I'm going to come around this pyramid, build up the top part first, come out only as needed, and then work my way down. And that's how you end up getting an improvement here without causing problems and getting a full restorational improvement. And you do this in 3 different zones that you can see, always starting from the front, working your way to the side. And it's number 1, the under eye. That's your first little triangle that comes around the edge and it stops here. Your second one comes, if you follow it from here, it's the inferior zygomaticus. And you can see that on everybody. Inferior zygomaticus. And you follow it around to the top of the superficial malar fat pad. And the last one is going to be just above nasolabial, coming across and falling into the contour line. So these are the 3 triangles or pyramids that you'll see around. And you can see them on someone's face as a depression on the anterior cheek that collapses and is largely responsible for deepened nasolabial folds. Most people think nasolabial folds are because you lost piriform volume. That's absolutely not true. Absolutely not true. That's not why you get deepened nasolabial folds. You get deepened nasolabial folds, the majority of it because of deflation of the cheek in that z-axis, and this much of it because of drooping. So you do have some contribution from drooping, but not a ton. You do have some, right? You can see it goes away, obviously, but the rest of it is from deflation. So when you're trying to fix a nasolabial fold with fat grafting, for example, you want to start with the under eye, work your way right over here, come down to the next one, work your way across. Then you got to figure out the last thing, am I injecting in layer 2, layer 4? Layer 2, you could be at the top of layer 2, bottom of layer 2. And that affects your muscle function and how it moves the skin. Under layer 3 becomes layer 4, and you have top of layer 4, bottom of layer 4. Top of layer 4 is directly subsmass. Bottom of layer 4 is supraperiosteal. And you can pick. Those are 2 different things. And that provides muscular support to areas like the zygomaticus so it doesn't flex inwards. And if you see it holistically like this, then you start to fix everyone's cheeks all the time without it having gravitational problems like you see with the chipmunks all around Los Angeles. A lot of chipmunks in LA.
So if you're looking, just to make it even simpler, if someone were to say, like, listen, if I'm going to be safe in order to do a cheek, if I just aim for the deep lateral medial SOOF, to inject there with either Sculptra or HA filler, I know we're kind of like skipping the whole triangle thing right now, but now I'm just saying, like, if someone is newer and they're looking to stay as safe as possible, would you say that's probably the better place to inject?
Yes and no. So Sculptra can't go in the SOOF. It'll cause major problems with ropiness and firm nodules and things like that. So sculpture can't go there. But let's say you're replacing volume, either HA or fat. Yes to the SUF, yes on the bone, yes from here to here. As you get right over here, when you smile, you see you get that flexion. You can smile and you can feel them. Those are your levators. People don't ever check. Like put your finger there and smile.
Yeah, Equinasi, meeting with your...
Yep, and the levators. Yeah, exactly. So it comes right down over here. That's stuck to the bone. If you ever inject onto the bone here, on this medial portion where you feel that flexion, I'm making a funny face, but it'll go into the muscle. And then you inflate the muscle, and now the muscle gets a strain when it flexes, and you get a ridge every time you smile, and then you get a depression on your superficial malar fat pad. So that's the exception.
Sometimes I see whenever people, I'm like, how did you get filler up there? I'm wondering if that's actually, is likely the case? They went in too deep, and then all of a sudden I kind of like creeped up there. Is that a possibility?
Yeah, I'm not sure, but
because I could see like an indentation ridge, and I'm like, I don't know who would put filler there, but I'll try and dissolve it.
Yeah, I've seen it all the time. I think it just migrates up there. From smiling, it kind of pushes it, but definitely you get that ridge, and you see that with filler all the time, where people inject it onto the bone here, not realizing the muscles on the bone there.
Yeah.
So if you're going the most medial part of the lid, you actually have to go under 1, 2, and 3. This is 1, 2, and 3. It's so thin there, you have to go directly under it. So you put a daughter filler under orbic here. And then here you're in the SUF.
Yeah.
And that's the best way to do that. And then you work your way down from there by palpation and kind of feeling to see where the deflation is. Because you can see deflation when you're sitting someone up.
Yeah.
Once you lay them down, it's gone. You can't see it. So you have to feel for it. And there's 2 ways to inject somebody, sitting up or laying down. And you got to pick which one you want to do. There are 2 different approaches. Neither one is wrong. They actually help each other. So in some cases, you do have to lay them down. Let's say you're doing a temple filler. The only, I'd say, really precise way to do a temple filler is laying down. Because all you're doing is palpating that deeper fat pad. Superficial injections, sitting up, who cares?
Yeah.
Volumetric deep injections, structural support, let's say,
yeah.
You got to lay them down and feel it because you want to feel where the depression goes away.
So a lot of injectors, like top injectors right now, they're a huge advocate for doing the superficial injections with a cannula. The only issue
in what areas?
In the temple.
That's stupid. No, that's anatomically stupid. So nobody can argue with that.
The reason why I think that, so they're doing it for the safety. They're saying that basically they're now moving away from the needle injection. Although Allergan just approved the needle shotgun technique.
Yeah.
They just literally approved it, which is ridiculous because I see it all the time on an ultrasound. The artery's right there, right on the bone, where it was supposed to be avascular, which doesn't make any sense. But
it's also the wrong plane for injection. But I'll tell you.
So they're placing it superficially because basically you don't need as much product. You're going to be able to push everything out a little easier. For me, my issue there is the skin's pretty thin here for a lot of people, especially women. Whenever they're getting it done, I feel like it's almost translucent for certain people. And if I place hyaluronic acid there, that superficially, I'm almost asking for a tindle. First of all, the other thing that I'm looking at is your lymphatics must be pretty much in that area. Like are there lymphatic like drainage cysts? I know that it connects to the lymph nodes and they connect the mouth, the nose, and the eyes. But there must be lymphatics that are connecting from the outside, and that likely could be contributing to issues as well. Because from what I read and heard is that your lymphatics can't be found in a dissection of a cadaver.
Cadaver no, but you can see it in people.
But it's usually running superficially.
They traverse from superficial to deep. You can see them when you retract something up. You'll see the little channels everywhere. Most people don't even know what it looks like.
Really?
But yeah, you can see them all over the place. So here, it's super simple. All those definitively they're stupid techniques, and I'm not just being. It's definitively stupid. It's like there's no better way to say how it's stupid. It's like definitively. If I open up a cadaver and show you, and you may have seen the cadaver, you'll see layers 1, 2, 3 are stuck together. And think about this also. Is temporal hollowing an aging issue or is it a design issue? Is it like, let me just design somebody's fucking temple and make it big or full, or did they age and it hollowed?
Yeah, they aged and they hollowed.
Okay,
yeah.
So if it aged and it hollowed, which I'm directing you to that answer, what do? You find where it hollowed.
Yeah.
It's not that hard.
So my response to that is like, but you're not replacing it with fat. You're replacing it with HA. So like HA doesn't really go anywhere. It's not supposed to go really anywhere. It's a synthetic product.
It can, but in general, you have to think about it like this. Over here, if you know the anatomy, you have this is layers 1, 2, and 3.
Yeah.
It's gliding in layer 4 over layer 5. The deflation does not happen in 1, 2, and 3 to any substantial extent. You get a little bit, and you get little color changes there, but that's about it. Then you look at layers 1, 2, and 3. Layer 2 is a palisading fat cell layer. It's not pyramidal like here. Here's pyramidal, here's palisading. Earlobe is palisade. Palisade means you have ovoid fat cells that are lined up next to each other like palisades, like just like the cell layers, just like the Pacific Palisades. Boom, 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 boom. You're in that palisading fat layer. It's vertical fat cells. There's no way to integrate a filler in there. It just doesn't happen until you get to the superbrow, and then you get what we call the periorbita, where you have a fascial compartment that's deep to your SMAS. So in these areas here around the eye, you can inject sub 3. In this area, when you're injecting 2, you're just fucking somebody up. You are fucking somebody up. There's no other way. All you do is change the color of the skin, and you congest all the veins that come across here, and sentinel vein you've heard of. There's a bunch of those little guys around there that go deep. So that's number one. You're also not treating the problem. That's the major part. Yeah. You're not treating the problem. The volume loss was not in layer 2. It's obviously not in layer 3. That's the SMAS. Sub 3 is a fascial layer. It's obviously not volume loss there. That's the gliding part of the fascia, not the periorbita. So then you have deep to layer 5, which is your deep temporal fat pad. That's where you need to inject because it's a discoid fat loss in that fat pad, and you reinflate it. Simple as that. And I can get corrections so easily by fixing that every single time on every single person with zero risk, zero problem. Now, when you're injecting with a needle is the wrong instrument to use here. It's not you say I do this, you say I do that. A needle is the wrong instrument. So if you understand the anatomy there, when you're on the bone with a needle and you hit the bone supraperiosteal, you're automatically in the wrong plane. In the wrong plane. But people think that's where you inject. That's not the temporal fat pad. That's the muscle and the bone.
Deep. And you're probably injecting into muscle.
And you're injecting into muscle and infratemporal fossa. Yeah. It'll escape directly into the floor, going down towards the insertion onto the mandible. That's where the temporalis inserts. That's a direct connection. You never inject on the bone there. Okay? That's the mistake people make. They think the fat pad's on the bone, or somehow you're doing deep injection, and deep means that. We're not doing just deep injection. We're reinflating the deep temporal fat pad. Yeah. Deep injection escapes, and if you put a needle in there, number one, it escapes. That's the worst part about it, because it's going somewhere bad. 2 is there is vascular occlusive risk there. Yeah. And why would you ever take that?
That's right.
So if you use a cannula, you go at the hairline or behind the hairline, you break the superficial layer of the deep temporal fascia, and you push forward.
Perpendicular to the major arteries, which
is fantastic. But major arteries is usually posterior to you and at the line of the ear, so you're usually anterior to that, but they do come forward up here. We're a little lower, but 100%, you're right. And you push forward, you're automatically into the deep temporal fat pad. And then you inflate it with your finger to match the bony ridges that are bordering it, which is 1, 2, 3 bony ridges, and the sideburn. Pop it out, and you're done. That is fixing the problem. And it does it with no issues because you reversed aging. That's the idea. With volume, not with fat. Yeah. But you reversed the deflational process. And then they get fixed, and they have no other issues. So you didn't change color of the skin, you didn't get venous congestion, you didn't risk their blindness, nothing. So when someone says, I use a needle, you tell them, where are you putting your stupid-ass needle? Where is your stupid-ass needle going? And they'll say, down to the bone. What's down on the bone there? Is the bone flat, or is the bone going like this in the skull? Do you know what a skull looks like? They don't know what the skull looks like. Where is it going? It's going towards the mandible. It makes no sense. So
plus, it usually also just like, it's very difficult to kind of create accuracy, or you're just going to get a lump somewhere for the most part. Like, you're using a very thick filler, and it's like they have hollowing here, 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 and here, and here, but they're just putting one bolus here. Yeah, no.
Frustrates me. So you shall not inject 2 and 4 out here. As you get to here, you can inject 4 because you have what we call periorbita. And if you look here and here, there's an actual fascial area in layer 4. As you get towards the adhesive zones around these areas. But yeah, so don't get me started on like people who are like anatomists. Anatomists. Put me in a room with an anatomist.
So I've got one last question for you then. So I have various colleagues who are plastic surgeons, and I've had, plastic surgeons who I've asked straight up. I'm like, listen, deep plane facelifts, is this just a fad? Is this actually a thing? Or is this like just social media is blown out of proportion? Everyone wants it because the top plastic surgeons are saying that that's, the best way to do it. And they are straight up telling me there's no difference. There's no difference in success rate. All the studies suggest that if you do a regular facelift versus a deep plane facelift, you're going to have the same outcome. It's just a different, maybe mild technique, different, and there's no benefit. And then the second question to that is, so for me, what I understand about, there's a very, very, the most simplistic way for me to kind of get an understanding of a deep plane facelift versus a regular facelift. A regular facelift is taking your fat pad, your superficial fat pad, and your skin and tissues, kind of moving it back. With the deep plane, you're kind of going in between the SMAS and the muscle. But the next question about that is, I've heard plastic surgeons say SMAS is just another word for muscle. So
superficial muscle.
The superficial muscle. They're saying it's just another word for superficial muscle. So am I on the right track? Is there a difference?
Yeah, so first off, when you're analyzing these things, it's so easy. Like, people think plastic surgery is science. It is anti-science. Plastic surgery is like if the devil came up and like diarrheaed all over this world of science. That's exactly what it is. It's the devil's diarrhea. There is no science in plastic surgery. It just doesn't exist for the most part. There's actually a little bit, but like it's just non-scientific. The articles are non-scientific. The plastic surgeons, I don't think they ever took like an epidemiology course. I don't think they ever took statistics. I don't think they understand any of basic math for the most part. You know, they'll get like a 60% survival rate of fat in a population, and they'll tell the patient your fat's going to survive 60%, so I'm adding 40%, and you're going to have 100%. That's plastic surgery, just so you understand. These studies that they talk about, the main one that they talk about where they say there's no difference and they've proven it, was from, it may as well be like the Ice Age. It was from the 1990s, early 90s, 91. And they reviewed the study in 95. And it was a split-face study to compare the deep plane of the time, which I think was great that they were doing it, but it didn't really get the best results. They were kind of weird. People got paralyzed eyes, you know. So it was the beginning. And they were comparing it to SMAS plication. Since that time, SMAS plication has had a couple different iterations, and deep plane has advanced massively. Yeah. So to compare it to the 1990s study, you're obviously living then. Your brain is back then. You forgot about the last 30 years, or you've ignored it. Yeah. And that's really where the translational issue becomes, is they keep looking at that. They say, no, they proved it. And I say, okay, let's just forget your stupid science for a minute, because you're bad at interpreting things. You're bad at understanding things. Let me just open my phone for you here. And I'm just going to, just not to show off here, but like, here's the last,
so just the
here's the last 20 facelifts I did.
Yeah.
And I say, go through this. How much better are mine than yours? Yeah. Oh, well, you're just a good surgeon. Yeah. Is it just because I'm a good surgeon? Or is it because I understand the anatomy better and how to manipulate the anatomy better than you do, because you have a different understanding of the anatomy than I do? They don't see it that way. They see it as though maybe I'm just a lucky guy. So they don't focus on the aging process. They want to have, support their egos and semantics and word choice to make themselves feel better and to promote their own business. That's why they do it. They're butthurt that somebody else is coming and asking for a deep plane, and that's hurting their business model. I don't care what you call it. I'll just tell you the process of aging. The name doesn't matter to me, deep plane or not deep plane, because there's a lot of confusion within deep plane. Even deep plane surgeons don't understand the variety that exists within the deep plane world, because there's so much and it's very confusing. The general gist of it is kind of what we were talking about with midface deflation and descent. Okay? You have two types of descent. You have this in your glide plane, and that is not debatable. Yeah. Open a cadaver, fillet a fish. Like, have you ever filleted a fish? Like, there's a plane there. Okay? Between two muscles, there's a plane, or else the muscles would move together. And by chance, this glide plane is where gravity has its effect. Lay someone down, sit someone up. Lay someone down, sit someone up. Gravity has its effect there. So if you want to lift the face where it came down from, you have to go directly where it aged, where it moved, and release it and put it back to where it was. Simple as that. That is your deep plane. That's your subsmass plane. In this area, it is your subplatysma, which is between the platysma and the masseter. Up here, it's going to be subfrontalis, between frontalis and periosteum. Straightforward. Most people understand that about the deep plane. They may ignore the major benefits of it because they're focused on retaining ligaments and all this other stuff that doesn't exist. But they get the general gist of it. Where they get really confused is the midface, because the midface, if you go under the muscle in that glide plane, you're going to end up paralyzing the nerves. Fortunately, in this area, the SMAS is pretty tight. It doesn't move that much. This is a big, giant spanning SMAS with not a lot of adhesions underneath. And then here has a lot of adhesions and doesn't really move that much with age. So you get more deflational problems here. So let's say you went just above the muscle. Then you can lift a little bit of the soft tissue, being layer 2 and layer 1, and reinflate the rest. Et voila. That's maximizing anti-aging. But you ask a surgeon, well, no, that's just subcutaneous, because they don't understand layer 2. Layer 2 can be fascia, as we said. It can be fat. It can be a lot of fat, depending on where you are. And that's very substantial kind of contributor to volume in certain places and redistribution of it. So the main difference is that mass plication surgery, you cannot argue this. It is non-anatomic. Nobody aged in layer 2 in a glide. They didn't droop in that plane. 1, 2, and 3 went down together on every single person. It's always what happens. So you can't argue that. So if that's what went down, why are you lifting above it if you don't have to? And that's what somebody's saying, well, I have to sometimes here. Fine. So mass plication is a non-anatomic surgery. Now, if you want to pinpoint the problems with it, there's a lot. One is you're actually grabbing the muscle, rhizorius, zygomaticus, and you can be pulling them in the wrong direction. Most people pull zygomaticus in the right direction, thankfully, when they do a mass plication. Almost everybody pulls rhizorius in the wrong direction. And what happens, you get something called a joker smile. Mouth widens. Have you ever seen or heard a patient saying, I'm scared my mouth's going to get wider?
Yeah.
Surgeons don't even know why that happens. It's not because they pulled the skin on the top. It's because they went to the middle layer and they grabbed the middle layer and pulled it. That's what moves the corner of the mouth. It's not the skin. It's the middle layer. They grab rhizorius, anterior part of parotid, buccal capsule. They pulled it. And they take it laterally or superior laterally. And then someone's mouth just goes, fish hook.
Yeah.
So there's a lot of problems with it in general. Now, I say go do whatever you want. I'm not trying to convince a mass plication surgeon to be good. The shittier they are, more people come to me. I'm happy with that. I don't care. But don't argue with me ever saying it's an anatomic surgery. It's non-anatomic. Everything we do is non-anatomic. We're cutting someone's face open who's healthy. That's non-anatomic. That's a bad idea. At least when you go in there, try to figure out where it came from, put it back to where it wants to go, and align things back to where they should be. So the next person who comes in doesn't need a roadmap. They go in and they see everything is where it should be anatomically. When it's like that, people age better, a lot better, and they function better. And that's the big, big difference. And again, forget the science. I can describe the anatomy and shit on the science, okay, to ways other surgeons don't understand. Very easily I can do it. And I can just show surgeons, and there's no arguing what I'm showing them because it's basic anatomy. I go so basic, you can't argue it. That's how it is. I'm not out there like these other surgeons are. But if they don't get that, I just show them my pictures and I say, look at my photos. I go over and over. This is not the best ones like you're showing in the past 20 years. This is Monday, Tuesday, Wednesday, Thursday, Friday. Every single day I'm getting the same kind of improvement because I understand the anatomy better. So deep plane in general is better, in general, because it's a more anatomic approach, but it doesn't mean the deep plane surgeon is going to get a better result.
Okay.
So that's for the patients to understand. For the doctors, it's don't argue with me about deep plane. For patients to understand, it doesn't mean that the deep plane surgeon is going to get you a better result. Because you could be going to a 5, you could be going to a 6, and in those situations where you're comparing 1990 surgeries, yes, they are equal, and you can get a good result, which is not in my world good, but your world good, not you, but, from a mass plication, and a good result from a deep plane. For the patients to understand. But don't compare it to my photos. Like, don't even get close.
Yeah. So another question I get from a lot of my clients, they're asking me, I don't know why they ask me. I'm not a plastic surgeon, but I just can refer them someone. But they seem to get mixed reviews, or they feel like that plastic surgeon is maybe just trying to push them to get the full surgery. And the question is, they just want a mini facelift or a mini lift. Is that a thing? And is there certain recommendations for it? What's your take on mini lifts?
So it's a little confusing because a mini lift in general means mini result, massive scarring for the most part. Because in a mini lift, what a surgeon's trying to do is little cut, peek in there, and just pull on things. But they don't move when you don't release them properly. And then you end up with tension, you end up with scarring. Okay. So for the most part, I tell people don't bother with this mini lift stuff. But there are some cool mini techniques that address the neck actually. Totally different. So you can actually see in the neck, there are mini techniques, meaning less invasive or less comprehensive, where you can go in and just manipulate the neck. And it can be something from as small as My Elevate, which is Greg Miller's technique, where it used to be called the trampoline lift, and they can manipulate the platysma to go up, or mine internal deep plane neck lift, or Mike Nyack's where you can actually make incisions here or here and here, access the muscle and lift it. And that's a type of mini lift. But in general, if somebody says mini lift and you're getting it mini because you're younger, no.
Okay, yeah.
It's either done right or it's not done at all. That's how you have to think about it, because you go in there and you do this little mini shit and you start to pull a little tiny bit and you think it's a little movement, you get no improvement, you can look a little weird, major scar, and then you end up in my office, all I went was for a mini lift, I should have listened to you. And so that's really what happens. So it's the world of release. You either release it properly or just don't do it. Go do something else. Go do some fat, some profound, some matrix, some Morpheus, whatever you want to do. Go do something else. Don't waste your time with this mini stuff. But you can do mini neck lifts in general, where it's like just a neck lift if you're a younger patient.
So a lot of our clients who come in and they, mature neck, not necessarily needing facelifts, but at the same time, there is some droop here, or there's something that causes like crepiness. And they're asking, can I just do microneedling radiofrequency? Can I inject it with like hyperdilute radius or something to add some volume in there? And for me, the results are always like, meh,
Yeah.
Is that because they likely need a neck lift? And is what they're seeing actual crepiness from the skin, or is it just, needing to go back?
So part of it is, not much of it is facial skeleton getting smaller, not much of it. Most of it is larynx and hyoid moving down a little bit, or the muscle starts to glide down from the face onto the neck.
Yeah.
And you get deflation in layer 2 usually over here, so you start to get more folding of the muscle. That's what you see. When it's minor, I really just tell those patients, hold on. I'm like, there's no great solution for you. You don't have to be 10 out of 10.
Yeah.
I know you want to be, but it's not worth the trek. You're going to have to do a lot of work to get it, or you're going to do something else that's not going to work so well. There are some patients that benefit from Botox. Some can do microneedling radiofrequency. Some can do fat grafting if they're really, really, really bad. Really, really bad. You can do some fat grafting. For most part, it needs to be lifted somewhat, and nothing else going to give a great result unless you reposition that muscle, which again can be done sometimes with this like MyElevate stuff, sometimes with more minor things. But most patients, they're not going to get big movements from any other of these techniques we throw at them. So I just say, wait till it's worse. You look fine. You're only showing me this in like 2 out of 10 photos. Calm down.
Awesome. For the conference that's going to be coming up, man, this is like amazing questions. And I love this style of where it's just kind of like being completely honest. And at the same time, no one's lost whenever you're speaking. People really grasp what you're saying. Is that what's to be expected at this conference? Like because I'm speaking there, I'm going to be, doing my thing with injectables. What's going to be the difference between this conference and another conference for either combination of injectables and plastic surgery? What should people be expecting whenever we come to this conference?
So they should expect exactly what you're saying is the lack of esoterica. Exotica is great, esoterica not so great. Nothing that you have to stretch your imagination to understand. Everything I say you can grasp by looking at someone's face, because my understanding of these things came from looking at people's faces. And I said this yesterday in my little Instagram thing. Most people, when they sit there at dinner and they have these creative minds, they start to think about ways to manipulate the face. And they go straight to the art of it. I'm an artist.
Yeah.
Okay. Mine is simply looking at the mechanics of the movement on the person's face and trying to understand. Like I did it to you 20 times. I just it just happens. I just think about it. And there's nothing wrong with your face. I'm not looking for the problem at all. No problem in your face. And I'm not looking for the problem. I'm looking to see where did it move? Why are his brows flatter than somebody else's? What's his frontalis doing? So I'm just looking at the why of all these things. And then when you understand the why, then automatically the answer comes for the how. Most people don't get that. They're always looking for the how do we do more? How do we do more? I failed because my technique wasn't good enough. I failed because my technique wasn't good enough. Technique. Not I failed because I didn't understand what was happening underneath.
Yeah. And
that's where I go, and that's how I explain things, and that's how I learn things. And that's why people always tell me, surgeons, they're like, it's so weird that you say the opposite of everybody else. And I explain it because my starting point was different. I went that way.
Yeah.
They went the other way. I started figuring out how to sharpen my axe better rather than starting chopping down the tree. I went the other way. So yes, in the conference, expect that. That's how I teach, and that's how I think most people have benefited from the things that I say very quickly and easily. And I have a lot of surgeons who I've taught, and they always say the same thing. They're like, it's always been a struggle for me to understand until you said it, and boom, it made sense. And they haven't even put it into practice yet, so they haven't had a chance to test what I said.
Yeah.
But it just made sense to them. So that's what the whole Cupid thing is kind of clarifying things for people so you can see inside. You shouldn't need to have an MRI. You shouldn't need to have an ultrasound to understand. It's actually harder to learn those things. I mean, they're great to have, but it's harder to understand the face with an ultrasound when you're putting an ultrasound probe on it, putting your needle in it. It's really hard to see those things. It's easier to just remember what it looks like inside, understand the tone of the face that you're looking at, look at the muscle motion, look at the mobile planes, the immobile zones, and then know what's happening and treat the face according to what you're seeing there. So that's the idea. That's what we'll teach. And then we'll see a couple other perspectives from my friends who don't see things the way that I do to give a little blend. And we didn't invite anybody stupid, so it's not going to be any kind of stupid blend. It'll be like intelligence blend.
Yeah, and even if they can only retain 10 or 20%, then actually that's the benefit of the Cupid Compendium. Then, they can kind of go back and, if there's any refreshers that you need, it's all there. Which is great, man. I'm looking forward to it.
Me too. I'm looking forward to the fun and the parties.
What's up, everyone? Dan Julien here, nurse practitioner for Dan Aesthetics Medical. I'm super excited to be speaking at the Cupid Compendium Conference this November. If you're anything like me and you really take your anatomy seriously and you're looking to take your game to the next level, this is the conference for you. It doesn't matter if you're an injector or a plastic surgeon. This conference blends everything perfectly and seamlessly together. And we do it in a way where everyone can understand. I'm super looking forward to it, and I'll see you there.
The first major Cupid Compendium conference is happening this year, and we're going to have an amazing lineup of injectors and surgeons to really bring together the injector and surgeon world to teach both sides better ways of approaching the face and really understanding the anatomy in the most basic, easy to understand ways that hold true to reality so you can go get the best results for your patients and make yourself proud finally. So I hope you guys all join us for the Cupid Compendium Conference. It's going to be in West Hollywood this year, this fall in LA.